the average number of dreams, the average length and duration of REM activity is decidedly less than individuals who are not alexithymic. And it would appear at this point, from various studies of alexithymia, that the problem is that patients suffering from this condition, which clearly is a hemispheric imbalance in that they use the right hemisphere for one function, they do not use the left hemisphere equally in fusion. In other words, there is little integration. And most of the studies that have been done in terms of the physiology of hemispheric integration indicates that the alexithymic patient tends to rely largely on the left hemisphere to express language, to verbally mediate what's going on, but have very little access to the perceptual, emotional aspects. Some French investigators a few years ago found that even very young infants can have sleep periods in which there is almost no REM activity. When followed up, when they became more verbal, these children, these youngsters, tended to be alexithymic. They had great difficulty in relating their emotions to adequate words. And in studies of patients, borderline patients, particularly patients with psychosomatic disorders, it was found that there is no real effective fusion between the imagery and the linguistic functions, between the right hemisphere and the left hemisphere. We took a group of alexithymic patients. As I say, they cross a variety of diagnostic lines, and we utilized hypnosis in ways that I will describe as we go along in order to create better integration between the hemispheres, in order to teach them in a way as you might teach organic patients who have had amnesias as a result of trauma or as a result of stroke, as you might teach them to begin to relate words to objects, where after carbon monoxide poisoning, for example, as you all know, many patients can look at a glass and say, that is a cup, but I don't know what it's for. I don't remember what you're supposed to do with it. There's a parallel with the alexithymic patient in that I feel something, but I don't know what it is I feel. And we have found hypnotherapy to be particularly effective with alexithymic patients in being able to bridge this gap and to integrate it. I have a few slides which will illustrate some of the major points of this study, and if somebody could show the first slide, and hopefully today it won't be upside down, but I don't guarantee that. We'll try to get it in the right perspective. We'll get it centered on the wall. The major parameters of the alexithymic population, the alexithymic patients in this case. And the data which is included on this slide, and which I'll elaborate on to some extent, comes from fairly extensive clinical interviews and fairly extensive, more extensive, psychodiagnostic testing. The testing included Rorschach, thematic apperception test, the Minnesota multiphasic inventory, and Bender-Gestalt test, a variety of neuropsychological testing, as well as personality dynamic testing. And these are the major findings. There are many other characteristics, of course, of alexithymic patients, but we only included those characteristics that occur in more than 70% of the population, 70% of 54 patients in this group. Other characteristics, for the purpose of our presentation, we discarded because if they got below 50%, then they were too randomized to hold to a generic model or to a generic characterization of what alexithymia presents clinically. Primitive oral needs. These were individuals who were very needy. There was a great deal of orality involved. They had all of the characteristics of individuals who have this grasping, controlling, verbal obsessiveness as a dynamic of their personality. They were infantile in terms of personality structure. They tended to use mechanisms of denial and avoidance. They tended to resort to childlike behavior as a means of coping with stressful situations. They presented a picture, even in clinical interviews, of being very infantile, so that, for example, many of them, when interviewed during initial clinical sessions, when asked questions about their lives or themselves, would giggle, would laugh, would turn things into semi-jocular, comical situations as a means of defense, and as such were characterized also by regressive needs in terms of their infantilism. Denial, as I say, was a major factor in their presenting histories, in their presenting problems. The ego functions were largely regressive. They relied a lot on primary process defenses. They were engaged in feelings that tended to be primitive, which they could not verbalize, which they could give little insight into. There was a lot of aggression, a lot of hostility, but all camouflaged, all masked, all defended against. They presented good facades, in fact, very good facades. There was nothing loose or flaky about their defensive structure. It was coarctated, very constricted, and that was the dynamic picture. There was also evidence, particularly from the psychometric and psychological testing, because they would give too little information that you could get clinically, about massive psychic trauma. The inference, particularly from Rorschach, was that these individuals had suffered early trauma, severe emotional trauma, some of it abusive in nature, and that they had defended themselves totally against trauma by removing themselves as far as possible. These were individuals who tended to distance themselves from emotional stimuli, who tended to distance themselves from conflicting situations, who tended to distance themselves from any aspect of confrontation. And the most important of all, and this was in excess of 85% of the population studied here, they had a very limited ability, extremely limited ability to symbolize and to conceptualize. And as such, they had very little retrieval of images or of memories. They were not, however, unresponsive to hypnosis, so that as one looks at some of these characteristics of alexithymia, one might say that these would be very resistive people. And they were no more resistive than patients with other dynamics. They responded well to the induction of hypnosis. And the difference between them and other patients, such as I described yesterday in sensory hypnoanalysis, is that they were very unproductive. When asked to do things, they said, I see nothing, I visualize nothing, I feel nothing. They were compliant rather than cooperative. And I think this is one of the important distinctions between the functional effectiveness of hypnotic interventions in many forms of therapy, is that when resistance is strong, there tends to be compliancy on the part of the hypnotic patients. Where resistances are more malleable and have more flexibility, there tends to be overt cooperativeness. And that cooperativeness is part of that therapeutic alliance, part of the involvement, part of the attachment. In the other case, you have distancing and you have compliance and not cooperation. And the distinction is a very subtle but a very powerful one. These individuals had very limited ability to symbolize or to integrate what experiences they had and how to extend and express those experiences in language that other people, particularly a therapist, could understand. All right, I think we can have the second slide if we might. These are the presenting clinical characteristics of this 45 group population. They had multiple physical symptoms. Their symptoms ranged from paresthesias to migraine headaches, to gastrointestinal complaints to a variety of mixed symptoms, but they had multiple symptoms. They were not a heterogeneous group symptomatically. They were a heterogeneous group symptomatically, not a homogeneous group. There was an absence of fantasy production. They had limited imaginations. They could visualize very little, if at all, and there was almost a total absence of the ability to engage in fantasy production. As I indicated earlier, they reported very few dreams, and in some of them who were studied in sleep laboratories, their retrieval mechanism was not the only point at issue, because the number of dreams actually reported by REM activity were less than might be expected for their age and for their general status. Their speech was of interest in that there were many repetitive details. They would say the same thing over and over again. There seemed to be very limited freedom to go beyond what had been said before. They might repeat the same thing with a slight variation in words and vocabulary, but when you ask them, tell me more about how it feels when you get depressed, they would tell you the same thing over and over again. They wouldn't vary it. They would never add more meaningful details. Some people find it a little difficult to go on and to tell you more, but bit by bit they begin to remember. These people could not. There also was a history, for many of them, of medication dependency and for many, abusiveness. Many of them have been on tranquilizers. Many of them like to use tranquilizers. Most of the abuse, in fact, I'd say all of the abuse in this population, were by prescription drugs, not illicit drugs. Antidepressants, tranquilizing agents, benzodiazepines primarily, and they liked them. They felt that they helped them, and they did not want to give them up. Even when encouraged to give them up, many of them would carry them around with them on a daily basis, even if they used them less. Their cognition, number 6, was very concrete and very rigid. These people were overly literal. They were extremely literal. There was no room for expansion or to variations in their thinking process. If they said something was one way, it was precisely that way. If they said that the pain was in this part of their head, it never varied and it never was different. It was always exactly the same. When they talked about life events, it was again a very concrete rendition, a very concrete report. There's never any expansiveness. They lacked imagination. They were not unintelligent. They were a highly intelligent group. But one had to use a metaphor in a sense, one had to almost force words out of them. One had to almost force them to describe more about themselves. They were extremely reluctant. All right, I think we can have the third slide. Now, this slide represents this group of patients' response to hypnotherapy. Now, the hypnotherapy in this case was very similar to the sensory hypnoanalysis I described in yesterday's presentation, in which they were encouraged to feel the body, to become aware of the body, to develop associations to the body, and at first, free associations to the body, free associations to sensory components of the body, and free associations to thoughts that they had. And it was done in a repetitive manner. Since these people were repetitive to begin with, we found it very helpful to employ repetitive procedures so that they were told, you are going to have an image of the house you lived in as a child. When they were first asked to do this, nothing would occur. Then they were asked, you're going to have an image, a mental image, a picture of the house you lived in as a child. And this was repeated sometimes 15, 20, 30 times. Very similar to the technique described a number of years ago by Norman Cameron at McGill called psychic driving, in which He used it primarily with obsessive-compulsive patients who have the constriction of our alexithymic patients, although they're a homogeneous diagnostic entity. The psychic driving technique is simply to take the same idea, the same words, and to drive it over and over again. Those of you not familiar with Cameron's contributions know that Cameron used these procedures by putting them on tape recording because he found it too difficult to repeat it. And he would expose the patients, sometimes in hypnosis, sometimes without hypnosis, to psychic driving on affective levels by having the tape repeat the same idea, the same instruction, 200 or 300 times. And he found that this frequently would then force expansiveness. It would create and foster free associations. It would help diminish the resistances and the defenses. So we use a procedure very much like that, and like what I described yesterday, in terms of focusing on the body, feeling it, smelling it, using all of the sensory apparatus, so that they were told that they could do things which to them sounded very strange. For example, they were told, you will visualize a color, any color you like. And then after some trouble, when they got the color finally, they were told, now focus on the color, center on the color, you'll become preoccupied with the color. We were using techniques that are very much like an obsessive-compulsive. You will be aware of nothing but the color right now. And then you're going to be able to feel the color. And strangely enough, where at first they couldn't feel anything, they now did something that most people don't ever do. They began to feel the color, and they described feelings in connection with the color. And some of these feelings were traumatic, some of them were joyful, some of them were stimulating, but they began to respond. We then produced increased dreaming this way, increased fantasy activity, and in the dreams and in the fantasy, there emerged a good deal of transference feelings. A lot of them were negative. A lot of them were very hostile. And later on, as I present some clinical material relating to this one or two cases, you will see how that became expressed. But the important thing was they were now dreaming. They were now recalling many more dreams. In fact, some of them were subject to a procedure where they were not too resistant to it that we call emotional flooding. We were told you're going to have lots of dreams. In fact, you're going to be overwhelmed by dreams. You're going to dream all night long, and you will remember them. In this case, there was no qualification, as I mentioned yesterday, where you can remember the dreams if you want to, but you don't have to. Here they were told, in effect, you have to remember the dreams. We just took out the passive part. We said, you will have dreams. You will dream constantly. You will find them to be important dreams. You'll find them to be productive dreams. We added positive elements, but we didn't give them the leeway of saying, you don't have to remember them, but you will remember the dreams. And many of them, in the following session, would come in, and they were encouraged to write the dreams down. On a given night, they might remember 6, 7, or 8 dreams, whereas prior to this, they would remember maybe one dream in 6 months, if they remembered that. There was a marked difference in their nocturnal dreaming aspect. And as a side note, something we can discuss at a later point, when nocturnally induced dreams become more frequent, hypnotic dreams become more accessible. In other words, whereas it was difficult to elicit hypnotically induced dreams during a therapy session, when we were successful in getting the nocturnal dream mechanism to be productive, then the hypnotic dreams also became much more responsive. Then we began to be able, with sensory devices, I think I will put this down on the floor, a little too large. We were able to get abreactive experiences. They began to abreact. They began to abreact to their own sensations, to their own feelings, to their fantasies. And the abreactions were very emotional, they're very intense. And of interest in terms of the abreactive responses, abreactions fell into 2 categories. Those which were overt, and some of them involved acting out, some of them were revivifications, some of them were spontaneous regressions to usually points of trauma. And they did not have specificity with regard to age. And I think this is important, as we've been talking a lot about regression these past 2 days, that much of the spontaneous regression that takes place in patients during sensory hypnoanalysis does not necessarily have specificity chronologically. It has specificity traumatically. In other words, they go back to the traumatic elements that they were involved with, and they don't necessarily remember at what age it occurred. They think it may have occurred at a certain point, but they're not too concerned about it. They're only concerned with the feelings, and this was our important objective in this instance, to get them to the feelings. They now remembered incidents of being abused. They remembered instances of being punished. They remembered instances of great trauma. They remembered events physically. For example, one man was able to go back and remembered when he had his tonsillectomy and the way the ether was applied at the time and how terrified he was. When I asked him, how old were you when you had this? He said, I don't really know. But I'm back there now, I know what's going on, and he told me exactly what was going on, but he didn't know how old he was. Later on, we figured out that he was somewhere between 6 and 7. But the important thing is that that kind of regression is a regression which has a special name in the nomenclature. It has a special classification hypnotically. It's known as dynamic regression as opposed to chronologic regression. One does not have to think of regressions as being tied in to a time continuum which is chronologically oriented. The regression is more dynamic in terms of the feelings, and sometimes the dynamic regression is more valuable because it permits a bridge to develop between that trauma and other traumas which were like it. So that when he remembered being in the hospital, being given the anesthetic, being traumatized, and above all, what he remembered, most important as he began, was being separated from his parents and being taken in an elevator up to the OR. At that point, he was terrified. He was then able to do something that he never thought he would be able to do. He began to associate to other events. There was a bridge now, an affect bridge, an emotional bridge, to other kinds of anxieties later in his life, which were like this, but not as dramatic. Anxieties that took place at school, at work, in interpersonal situations, which had been totally suppressed, which had been totally pushed out of consciousness, now, very naturally and easily, began to come back in a normal flow, which he could describe with very little prodding, with very little questioning, with very little pushing at all. But this is characteristic of what has been described in the literature as dynamic regression. It is not just a specific regression to an age. It is a regression to an experience. It is a regression to a feeling. And from that, as Anna Freud pointed out a long time ago in terms of the nature of ego and ego defenses, that if you can get back to the child's first real separation anxiety and the trauma that that may have had in terms of the projective identification with the parent, and particularly with the mother, that recovery of that memory then serves as a bridge to other aspects of separation, of detachment, of a sense of loss, of ego loss, which deflates the ego and which, in Anna Freud's terms, was very strongly connected to the development of depression in early adolescence and then into adulthood. And here we find certainly that mechanism operates, that when that early initial traumatizing experience can be encountered and re-experienced, then there is the affect bridge, which moves clearly into other areas of related. And we might say that the other traumas are equivalent, they're not the same. Following the abreactions, and some of these abreactions, as I said, are overt. Some are covert, and we call those silent abreactions. Very often, a patient would be remembering something, would be sensing things in the sensory hypnoanalysis and not saying a word. And we would let them stay that way for sometimes 20, 30, 40 minutes. Afterwards, they would tell you what was going on, and they said, the reason I couldn't tell you, or I didn't want to tell you, I could have told you, is that it would disrupt my concentration. I think it is very important during this kind of therapy, and perhaps other kinds of hypnotic interventions, that when patients are obviously having experiences, particularly experiences that involve feelings, and you can tell this from muscle tonus, you can tell this from involuntary reactions posturally, you can tell it from a variety of physiologic type responses, that it is frequently important to let them have that experience quietly without verbalizing it, and then have them verbalize it afterwards. Because many of them will say almost precisely what I just described. That if I interrupt it, if I start to tell you about it, this is the silent reaction, it will take my focus